About the glomerular diseases. So we have what? We have podocyte, then basement membrane, then the endothelial cells. So we have the podocyte, then basement membrane, then endothelial cells. So this is called what? Glomerular capillary. This is the glomerular capillary. And then we have from outside urinary Bowman's space. So we have RBCs and protein. So we want to differentiate between the nephritic and nephrotic, and in between there is something called the nephrotic syndrome. So nephritic means what? A huge amount of RBCs, and there is less amount of protein. It's less than what? 3.5 gram per day, less than 3.5 gram per day. Then in nephrotic syndrome, there is less RBCs, but there is more protein, more loss of protein, more than 3.5 gram per day. So there is a protein in nephritic syndrome less than 3.5, the protein in nephrotic syndrome more than 3.5. Then nephrotic syndrome, it's what? It's nephritic and nephrotic at the same time, but it will go for what? For nephrotic syndrome regarding the proteinuria, so it will be more than 3.5. so it's a nephritic and the nephrotic syndrome. So but the proteinuria more than 3.5 gram per day. So we will speak about the nephritic syndrome. What's meant by nephritic? RBCs, but the amount of protein less than 3.5 due to what? There is glomerular inflammation leading to damage of glomerular basement membrane. So we spoke about these layers. We said that from outside podocyte, then basement membrane, then the endothelial cells. So there is what? Glomerular inflammation leading to destruction of this glomerular basement membrane, leading to loss of RBCs into urine. So while losing RBCs into the urine from this small areas, leading to dysmorphic RBCs, leading to formation of dysmorphic RBCs, leading to hematuria. So in nephritic syndrome there is what? There is hematuria and RBCs cast in the urine, leading to what? Decrease the glomerular filtration rate, which will lead to what? Oliguria, azotemia. So in case of decrease the glomerular filtration rate, there is a stimulation of what? Renin angiotensin aldosterone system. So leading to increase in the renin angiotensin aldosterone system. Aldosterone will cause what? Sodium reabsorption, potassium and hydrogen loss, sodium reabsorption, leading to hypertension. So in nephritic syndrome there is what? There is hematuria and hypertension, and there is decrease in the glomerular filtration rate, oliguria and azotemia, and there is a stimulation of renin release. But you must concentrate on what? Hematuria, hypertension, plus the proteinuria. We said what? The nephritic and nephrotic more than 3.5, nephritic less than 3.5. So it's called what? Subnephrotic range less than 3.5 gram per day, but in severe cases maybe in nephrotic range. So what's meant by nephrotic range? More than 3.5. so subnephrotic means less than 3.5. so nephritic syndrome there is what? There is hematuria and there is hypertension, and there is subnephrotic range, proteinuria. So proteinuria less than 3.5. so there are examples and we will discuss each one of them in next pages. So we have what? Infection associated glomerulonephritis. We have 2A immunoglobulin A Albert. So 2A. We have what? In nephritic syndrome we have 2A Albert syndrome, and we have immunoglobulin A nephropathy, which is called the Berger disease. Then we have Goodbusher syndrome, and we have membranoproliferative glomerulonephritis. So 2A, Albert, and immunoglobulin A nephropathy, and we have infection associated glomerulonephritis, Goodbusher syndrome, and membranoproliferative glomerulonephritis. So nephritic syndrome, there is what? Hematuria, hypertension, proteinuria, subnephrotic range less than 3.5 gram per day, and we have examples like infection associated glomerulonephritis, Goodbusher 2A, immunoglobulin A nephropathy, and Albert syndrome, membranoproliferative glomerulonephritis. Then nephrotic syndrome. So we spoke about nephritic syndrome as what? Glomerular basement membrane damage leading to loss of RBCs. But in case of nephrotic, there is what? Podocyte damage. So where is the podocyte? This is the podocyte, this is the basement membrane, and this is the endothelial cells. So in nephritic there is damage to the basement membrane, but here in nephrotic there is damage to the podocyte. So what's the importance here? Podocyte has what? Has a charge barrier. So if there is damage to podocyte leading to impairment of a charge barrier, so this charge barrier is negative, and there is albumin which is negative. So this charge barrier is responsible for inhibition of albumin being in the urine, albumin to be in the urine. So negative charge of podocyte leading to inhibition of negative charged molecules from basin leading to inhibition of proteinuria. But here in this case there is podocyte damage leading to impairment of charge barrier, leading to impairment of negativity in this barrier, leading to proteinuria, severe proteinuria, basin of what? Of negative molecules, negative albumin, basin of negative albumin leading to severe proteinuria. This proteinuria severe, more than 3.5 gram per day, with edema. Why? Because the protein is responsible for the oncotic pressure. So if there is loss of protein leading to what? Leading to edema, the fluid will go from intravascular to extravascular, leading to edema, because there is decrease in oncotic pressure, there is severe decrease in the protein, more than 3.5 gram per day. Then there is what? Hypoalbuminemia. Why? Albumin negative charge, and there is damage to the podocyte, the podocyte which has a charge, which is a charge barrier with negative charge. So if there is loss of this negativity, there is loss and passage of negative molecules like albumin, so leading to hypoalbuminemia. This hypoalbuminemia leading to reflex from the liver, leading to formation of albumin to compensate for this decrease in albumin. But this albumin formation from the liver will form another one with the albumin. What is another one? Lipids. So there is increase in hepatic lipogenesis with liver trying to compensate for this hypoalbuminemia. So if there is decrease in the albumin, there is increased hepatic lipogenesis leading to hypercholesterolemia. So again, if there is decrease in the albumin because there is severe proteinuria, so the liver will try to form new albumin. During formation of new albumin, the liver will form what? Lipids, lipogenesis, increase hepatic lipogenesis leading to hypercholesterolemia. Now this hypercholesterolemia will appear as what? Fruity urine with fatty cast, then this is the most important. If there is nephrotic syndrome, damage of podocyte, there is loss of what? There is loss of antithrombin 3, and there is loss of immunoglobulin G. These are so important. So loss of antithrombin 3 leading to what? Leading to hypercoagulability in nephrotic syndrome, because there is loss of antithrombin 3 leading leading to hypercoagulability. The second one, if there is loss of immunoglobulin G, leading to increase the risk of infection, so this is so important. The loss of antithrombin 3 leading to hypercoagulability, loss of immunoglobulin G leading to increased risk of infection, and of course soft tissue compromised by what? By the edema, because there is severe proteinuria, severe loss, decrease in oncotic pressure leading to edema. So soft tissue compromised by what? By edema. So examples for it may be primary direct podocyte damage leading to loss of a charge barrier, loss of negative charge barrier, or secondary podocyte damage to what? Systemic process, like what we have here, focal segmental glomerulosclerosis, and we have minimal change disease, we have membranous nephropathy, we have amyloidosis, and diabetic glomerulonephropathy. So examples for nephrotic syndrome, we have what? Maybe primary damage directly to what? The podocyte, or secondary to a systemic disease. So we have diabetes, and we have amyloidosis, and we have primary like what? Primary like focal segmental glomerulosclerosis, minimal change disease, and membranous nephropathy, and we have systemic like what? There is what? Amyloidosis and diabetic glomerulonephropathy. So we have nephrotic syndrome. It's a combination between nephritic and nephrotic. So this means what? There is severe damage of glomerular basement membrane leading to what? Nephritic. So if there is damage to glomerular basement membrane, there is loss of RBCs into the urine, because it's what? It's nephritic. So appearance of RBCs in the urine. The second one, nephrotic because of what? Because there is loss of podocyte, damage to podocyte, impairment of a charge barrier, of the negative charge barrier, impairment of it, leading to what? Severe proteinuria, hypoalbuminemia, because there is severe proteinuria more than 3.5, and of course there is hematuria from the nephritic syndrome. So nephritic plus nephrotic, so it's what? Nephrotic range proteinuria, because there is loss and impairment of a charge barrier, impairment of podocyte more than 3.5, and concomitant with features of nephritic. So you will find what? You will find hematuria and hypertension, which is what? Nephritic with what? With nephrotic range proteinuria more than 3.5 gram per day. Then it can occur in which case any form of nephritic syndrome, but most common with what? So it can occur with any form of nephritic syndrome. So nephritic will be converted into nephrotic. So nephritic form, severe form of the nephritic syndrome may be converted into nephrotic, and it's common in what? Diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis. So diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis causes what? Causes nephrotic syndrome. So can occur in any form of nephritic syndrome, but is common with what? Diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis.